Good morning, everybody. Thank you for joining us today. This is Andrea Rasser at IAMS. I am the Chief Underwriter here, and today we will be going over sleep apnea. This is something that we see, I would say, at least a couple times a week in the underwriting world, so I thought it would be a good one to go over with everybody. All right, so we're just going to jump right in because we've got a lot to go over. Let's get right into what is sleep apnea. So sleep apnea is a disorder in which your breathing reoccurrently stops during sleep. And this occurs long enough that it causes blood deoxygenation, or basically you're not getting enough oxygen in your blood. If an individual has sleep apnea, there are usually frequent episodes throughout the night in which breathing does stop. The prevalence in America at the current time, the estimate is about 25 million adults are dealing with sleep apnea on a nightly basis. What's interesting about this is about 90% of cases are undiagnosed, which means this 25 million number is probably much, much higher than what we realize. So the way that sleep apnea is going to disrupt sleep, these frequent interruptions, they cause really poor quality of sleep. Each significant episode leads to a desaturation of the blood oxygen levels, and this stimulates the brainstem in the respiratory center to arouse an individual from their deep sleep in order to start breathing again. Obviously, that's a problem. If you don't get a good night's sleep, you're going to end up with excessive daytime sleepiness, and there can obviously be a lot of consequences to that. These interruptions can be quite serious. Another interesting note is that individuals that have untreated sleep apnea are actually 2.5 times more likely to be in a car accident. And that doesn't just stop with car accidents. I mean, that goes also into work-related accidents and home-related accidents. So just kind of something to keep in mind there. It's not as simple as I'm just a little bit tired in the morning. So let's dig into the different types of sleep apnea. There are three main types. The most common type is going to be obstructive sleep apnea. This is about 90% of the cases we see. Obstructive sleep apnea basically occurs when there's a partial or a total obstruction to airflow at the level of the pharynx or the hypopharynx. This is more common in obese individuals than it is in people of normal weight. The second type that we see is central sleep apnea. This is actually only about 2% of our cases. We don't see it very often. This is basically, it's secondary to a primary neurological disorder that affects the brainstem respiratory center. It'll fail to trigger respiration during sleep, and the mortality associated with sleep apnea is largely related to the nature and the severity of the underlying neurological abnormality. It's not typically the sleep apnea itself that can increase the mortality. It is the underlying neurological issue that's prompting that central sleep apnea. So just a little inside there. And then the third that we see is mixed sleep apnea. And this is basically, it combines elements of both obstructive and central sleep apnea. And we do see that one quite a bit, but not near as often, obviously, as obstructive sleep apnea. All right, so who is most likely to get sleep apnea? Let's see if I can get my screen here to work. There we go. So sleep apnea can affect anyone, even children. It is not biased. It can affect people of all walks. But there are certain factors that do increase your risk. Some of these risks are going to be, again, obesity. 70% of people who have obstructive sleep apnea are overweight. This is because the fat deposits around your upper airway can obstruct your breathing. So that is why a lot of times we see sleep apnea go away with weight loss. Neck circumference, again, People with thicker necks may have narrower airways, and so this can be a concern. Alcohol and sedatives, both of these induce a deeper sleep, and they relax the muscles in your throat, which can worsen that obstructive sleep apnea. Smoking. Smokers are 3 times more likely to have obstructive sleep apnea than people who have never smoked. This is because smoking can increase the amount of inflammation and the fluid retention in those upper airways. And then other medical conditions. There's obviously more than just these few that I have listed here, but congestive heart failure, high blood pressure, type 2 diabetes, these are all conditions that can increase the risk of obstructive sleep apnea. What's interesting is sleep apnea also increases the risk of these same diseases. So it kind of goes both ways. You never really know which one caused the other, but they all are intertwined. So what are some of our symptoms with sleep apnea? Most of the most common symptoms are going to be daytime sleepiness. This is something that pretty much anyone with sleep apnea will talk about. Snoring. Snoring is the biggest symptom that we see. We see this in medical records all the time. It's usually noted somewhere along the lines of, my wife can't sleep because of my snoring. It's not always the snorer that does the reporting, but oftentimes the partner that recognizes this. Daytime fatigue, like we said. And that daytime fatigue and that lack of sleep, that can really cause a lot of problems throughout the day, with irritability, headaches, memory loss. It definitely has an effect on cognitive impairments, decreased concentration, all those kind of things. And so it's not as simple as, I'm just a little tired. It can really affect a lot of different ways. And especially when it comes to younger kids, it can affect their schoolwork and how they're participating and performing day to day in class. One of the other most common things we see or hear is a client saying they wake up gasping or choking. And more often than not, again, it will be a sleep partner that actually recognizes this, that, says, "Oh, my husband, I have to wake him up 4 times a night and he gasps and he jerks." And, it's usually a bed partner that presents these things to a physician. Um, so those are going to be the most common ones. What's also very interesting is that while it's very common for snoring to be one of the main symptoms, the majority of people who snore do not actually have sleep apnea. Um, that's just one of those interesting little tidbits. A lot of people snore and don't have it at all. So you can't just assume because your husband snores that he has sleep apnea. But it is, again, one of the more common symptoms. So kind of an interesting little tidbit there. We're gonna skip the Epworth sleepiness scale for right now. So when it comes to diagnosing sleep apnea, the degree of the sleepiness can oftentimes be assessed by what they call the Epworth sleepiness scale. This is a measure that doctors will give to a patient in the office. They have you basically give a 0 to 3 rating in a variety of situations and where you might fall asleep. So are you more likely, are you on a scale of 0 to 3 likely to fall asleep while you're sitting and reading or watching TV or sitting inactive in a public place, sitting quietly after lunch in a car, as a passenger in a car, are you likely to fall asleep? And so the scores for each activity are then added all up, and a total score of less than 10 is considered normal. Scores of 10 to 15 and 16 or more are going to be in that moderate or severe sleepiness, respectively. So when we're diagnosing sleep apnea, one of the things I do look at is that score. And then the other gold standard is going to be your sleep study or polysomnography. This is required in order to really define the severity of the sleep apnea and and to assess the results of any kind of medical or surgical treatment that's been done. So a lot of times you'll have underwriters come back and say, we need a follow-up sleep study. Well, why do we need a follow-up sleep study? Because we've already done the original one, they're being treated, they're compliant. Why does the follow-up sleep study matter? This is because that follow-up sleep study kind of determines if the treatment is working and how well it's working and if any adjustments need to be made. So the sleep study basically measures the apnea index, and this is the number of times that you stop breathing in the middle of the night, or the number of episodes of apnea. They measure these, they look at them lasting 10 seconds or longer per hour of sleep. So they count each of those that occurs. Then they also count the hypoapneas, which are more of a partial apnea. They still last 10 seconds or longer, but they get a count on those. And then they have the respiratory distress index, which is also called the apnea hypnoapnea index. You'll have, if you ever do questionnaires or pre-screen these, I may ask you for the AHI, which is that apnea hypoapnea index. This is the number of apneas and hypoapneas combined that occur per hour of sleep. In addition, they also look at the oxygen saturation. They want to see just how much oxygen you are maintaining or losing during these episodes. And then they also look at breathing patterns. There are home sleep studies that are available, but these are a little bit less reliable on the more complex cases. So we really like to see the ones that are done at these sleep study centers. All right, so where are we at here? All right, so when we look at treatment options, sometimes treatment is just lifestyle changes, it's behavioral changes. They look at weight loss. That is always a good way to see sleep apnea become better controlled. Sometimes it's something as simple as positional therapy. If you can train the affected individual to sleep on their side, if these apneas are more common while they're sleeping on their backs, then that is always a good option as compared to medication or devices. Sometimes just the reduction of alcohol or sedatives, pain relievers, sleep aids, those kind of things can make a big difference. And also getting hypertension or any kind of cardiac disorders under control can also have benefits to treating sleep apnea. Some of the medical treatments will include the use of some drugs, sometimes progesterone. In most cases, though, medications are ineffective. These are usually only effective in the mildest forms of obstructive sleep apnea. And so what we usually see are mechanical devices such as tongue retainers, jaw positioners, and the tried and true CPAP. I think anybody who's written insurance long enough has probably learned a little bit about CPAP. This is the treatment of choice in most cases of obstructive sleep apnea. This it's a continuous airway pressure, and it acts kind of as a pneumatic splint to keep your upper airways open during sleep. There are other forms of CPAP. There's another one known as BiPAP, which is just a bilevel positive airway pressure. It's auto adjusting, and so those can conform to your needs. So let's see. There have been some other treatments, but they have not consistently shown to be better than CPAP. And so that is what we typically look for and what we do see the most often. There are some surgical procedures that can be used to treat sleep apnea. One of those is reconstruction of the nasal canals. And then a tracheostomy, which is only used in very, very severe cases that are typically life-threatening. And then bariatric surgery for extreme obesity. Obviously, we bring the weight down, we probably get the sleep apnea under control. So that is obviously an option for some. Of all these different treatments, the tracheostomy has actually been shown to be the most like definite cure out there. But again, these are only used in extreme medical emergencies with significant morbidity. That it comes with significant morbidity, and so that is something we do not see very often. The most important factor in assessing the therapy, and especially CPAP therapy, is ongoing compliance with the treatment. If a client has been prescribed CPAP and they are not using it, that non-compliance is definitely going to stand out and cause debits from an underwriting perspective. None of these other therapies, including the surgical approaches, are really reliably effective. And so any kind of success really has to be documented with a repeat sleep study after that treatment is instituted. Let's see. What else do we have here? Compliance is key. Again, note that 50% of patients abandon their CPAP therapy within the first year. I'm sure nobody is comfortable sleeping with a big old heavy mask on their face, but it does make a big difference in daytime sleepiness and curative movement. All right, so when we are looking at the severity levels and the underwriting criteria, basically we have mild, moderate, and severe. In your mild category, that's going to be an apnea, hypoapnea index of between 5 and 20. So they only want to see these apneic episodes happening 5 to 20 times per hour max. The oxygen levels in the blood stay over 85%, and you have minimal daytime symptoms. So if you're just a little sleepy occasionally, and it's not ruining your entire day, and we're probably looking at mild there. Moderate, those apneic episodes increase to about 20 to 30 per hour. Oxygen levels decrease even more, down to 75%, and you do have mild daytime sleepiness and daytime complications. And then we move on to the severe, which is where they're seeing more than 30 apneic episodes per hour and oxygen less than 75%. This is where you start to see cognitive issues throughout the day and cardiac impacts and such. They also look at that Epworth Sleepiness Scale score. That is something that the doctors, again, will do right there in the office, and that's based on your own answers. And those they will incorporate when looking at the severity, whether it be the doctor or an underwriter. So when it comes to CPAP and underwriting considerations, preferred rates are possible with documented CPAP compliance and improvement. That is something that we look for instantly, is whether or not they've been prescribed a CPAP and whether or not they're using it. We will sometimes go and get the reports from the doctors to see how many hours per night it's being used. The reports usually will tell us how many hours per night and what oxygen levels it was at. Any kind of poor adherence to CPAP, we're going to see rate classes go up on that. It could be anywhere from 2 to 4 tables all the way to a decline. It really depends on the severity of your sleep apnea. If you have mild sleep apnea and you're non-compliant, that's not good, but it's a whole lot better than if you have severe CPAP and you're non-compliant. If you're severe CPAP and non-compliant, that's likely where you're going to start seeing the decline. So that severity really, really makes a difference on how we view the adherence on that. And let's see, so yeah, we had a couple case studies. We had a female, 34. She used her CPAP every night. She did everything the doctor told her to. She had a repeat sleep study to show that it was helping, and she was able to get a preferred rating. Within the same week, we had a male who was 55. He was very inconsistent with his CPAP use. He could not sleep with it on. He would try to put it on for a couple hours and then take it off, or he would not use it at all. And he did end up with a table 4 rating. And if I remember correctly, he had not done a follow-up sleep study. So we really had no way of knowing just how effective that CPAP treatment was. So when we look at CPAP and the cardiovascular risk, what we have found is that 50% of untreated sleep apnea usually develops hypertension. It also increased the risk of atrial fibrillation by 4, and untreated severe obstructive sleep apnea can actually shorten the lifespan by 12 to 15 years. Some of the other mortality considerations are that there is a higher accident risk due to your daytime sleepiness, whether that's a work accident, a driving accident, all of those things have to be taken into account. There is an increase of coronary artery disease. That combined with untreated sleep apnea actually increases your mortality risk by 3. Some of the things we see are congestive heart failure, pulmonary hypertension, different arrhythmias, again, like AFib. There's quite a diabetes, liver functions. Liver functions is another one. It can increase your liver function test and cause scarring on the liver. So that's just some of the ways it can affect your mortality there. And then sleep apnea patients who require oxygen therapy, that goes a little bit further than just sleep apnea. Those we're typically going to see a decline. They do not like to see anybody requiring oxygen during the day. All right, different rate class potentials. So for mild, untreated, preferred is actually possible if there are no additional comorbidities. That is going to be key. If you don't have hypertension, there's no obesity, there's no excessive alcohol use, COPD, diabetes, AFib, all those things. If none of that is in play, then preferred is possible. If it is mild and it is treated, then preferred is definitely possible, obviously. We move on to moderate. If it is moderate and untreated and without any other rateable issues like hypertension, COPD, all those things, then we're probably looking at the standard to table 2 range. Now, if we have comorbidities in play, then it's going to be a little bit different. Preferred may be possible if it's well treated, but if there's other conditions in play, you're going to be rated based on those conditions. They basically sum up all of those debits, and so that can kind of land anywhere depending on what the comorbidities are. For severe untreated sleep apnea, we typically see a table 4 to 6 from the carriers that are willing to offer on untreated sleep apnea. However, there are multiple carriers who will not offer on it at all if it is untreated and severe, and those carriers are obviously going to decline. And for the ones that offer the table 4 to 6, that is also assuming there are no underlying comorbidities, and that's just looking at sleep apnea alone. So if you have a guy who's not treating it because he can't sleep with the CPAP, yeah, there might be 1 or 2 companies out there that'll look at it at table 4 to 6, but we're definitely going to want to shop that because there's going to be multiple other companies that won't. And if there are any other underlying factors, then that table 4 to 6 is probably off the table. All right, and if you have severe sleep apnea and it's treated, believe it or not, preferred is possible. Now, with this, we are again assuming there are no other comorbidities to take into account and 100% compliance with the CPAP. They want to see nightly use, a full night's sleep, that Epworth Sleepiness Scale scoring being under 10. That's what they're going to be looking for. Preferred with severe sleep apnea, I will say, is not common. Yes, it can happen, but it is not something we see really, really often. You'd have to be really on your game and using that CPAP constantly and have perfect health otherwise. All right. So here were just a couple cases, like we kind of touched on a couple minutes ago here. We had a female. She was only 34. She was a non-smoker, which obviously helps. Build was wonderful at 5'6" and 190. She was on one blood pressure medication. However, she was compliant with that medication. Her last reading was 130 over 80, so we were seeing really good control there. The sleep apnea was diagnosed in 2020, so we did have a few years of records to see how things were going. Her AHI, or her apnea hypoapnea index, before the CPAP was 17. She did do a follow-up sleep study as directed by her doctor, and that apnea hypoapnea index dropped down to 0.8 with her CPAP usage. And with this, we had multiple offers at standard. We had a lot of companies that came back at standard, but we did have one that came back at preferred. So again, that great control and consistent follow-up, doing what she was supposed to do, that compliance, that all made a big difference and got her that preferred rating. All right, and then we had a more high-risk gentleman. This young man was 65. He was a non-smoker also, 6'3" and 255 pounds. His sleep apnea was diagnosed over 10 years ago. He did also have a history of hypertension and asthma, and he had some tachycardia issues and some neuropathy, which I assume was from diabetes, but that was not an official diagnosis as of yet. He did have a lot of different medications that we had to take into account. His apnea hypoapnea index was 9.2 during his sleep study, and the oxygen desaturation was at 89%, which was actually really pretty good. His asthma was noted as moderate and persistent, and he was prescribed 4 different medications. One of the medications was a rescue inhaler, and that had not been needed. So technically he was taking 3 medications, but we have to look at all 4. And with all of this, he was declined by 2 different companies. We had multiple companies come back at table 4 to 6 because he was compliant with using that CPAP. And then the best offer that we saw was a table 3. All right, so when it comes to underwriting now, obviously we are always going to look for an APS. We need that attending physician statement to verify the diagnosis, confirm any improvements with therapy, and verify good compliance with the treatment plan. We're going to be looking for that sleep study result. They're going to be looking for that AHI, or that apnea hypoapnea index. They're also going to look at compliance and the absence of severe comorbidities. That's, again, always going to be key. It's very rare that we just see one health issue at a time. There's almost always others involved. So one of the things agents can do if they have a client that they know has sleep apnea is always encourage the client to be compliant with their CPAP. If you know they've not been compliant, it might be worthwhile to talk them into compliance and have a good follow-up with their doctor documenting that compliance, because that will help with their rate class in the long run. And then if untreated, if your client says, you know, they've got it and they refuse to use their CPAP, they hate it, they're not doing it, then prepare the client for the possibility of a rated offer or even a decline. It's always good to educate rather than oversell and underdeliver. You know, make sure the expectation is set so they know exactly what to expect and what is going to be looked at there. And some of the key takeaways that we would like to point out is that sleep apnea is very common. This is something I literally see multiple times per week. It's not new and it's not going away. We see it all the time, so it's good to be well versed in that. Treatment and compliance equals better insurance ratings. Again, if they're not compliant with the treatment that's been recommended by their doctor, we're going to see higher rate classes on that. We will also see higher rate classes in situations where client goes to the doctor with his spouse and his spouse says, well, he keeps me up all night with his snoring and I have to smack him awake, or he wakes up choking and coughing. And then the client refuses to do a sleep study because it's no big deal. That's where we're going to start seeing those higher rate classes and those declines. And then, well, yeah, severe and untreated, that's where we get the increased risk. All right, and then yeah, helping clients understand their condition and manage those risk factors definitely improve their insurability, but most importantly, it helps to improve their health. It's not just about getting a good rate class, it's also about having a good night's sleep and being healthier. So how can IAMS help you with this? Well, we do have our case studies. But more so, we have fact finders. We have fact finders on our website that are very generic, that can be used for just a client's health in general. They can put anything and everything on there so that I can look over those and work with the agent to determine who the best carrier is going to be for whatever health issue we are up against. We also have very specific health questionnaires on here from our NAILBA guide. And with our NAILBA guide, this digs down into very specific risk. So there is one specifically for sleep apnea. There's one for every single kind of cancer you can imagine, mental health disorders, all those things. They ask the questions that we're going to need to know to really determine what an underwriting class we're going to fall in. And then we can shop those out. You can call me. You can email me at andrea@iamsinc.com, or we also have a pre-screen address, which is just prescreen@iamsinc.com. I can forward you those questionnaires, or they are available on our website. You can also get those from your sales director. But once I get those, what I will do is review them and send a pre-screen out to all of our carriers to see who is going to be the most favorable for the situation that is presented. Again, working side by side with your sales director. If you're not able to get a hold of me, feel free to talk to your sales directors. They know exactly where all of these pre-screen forms are at. They can send them to you, or they can direct you to where they are on the website. And just keep in mind that anytime we address these on the front end, we're saving a lot of time on the back end. There is nothing worse than starting with a carrier based on the premiums, based on a spreadsheet, just to find out that they're a carrier that's going to decline this. It'd be better to find out right up front who to go to so that we're with the carrier, the right carrier, the first time. And with that, don't forget to follow and like us. We are on Facebook, LinkedIn, and we sure appreciate your business and working with you every single day. Please feel free to give me a call with any questions you might have, and thanks for being here. Take care.